Good afternoon. My name is Kelly, and I will be your conference operator today. At this time, I would like to welcome everyone to the National Disparities LAN event, Driving High Performance for Chronic Disease Management Team. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Ms. Nia Lindsay with the Quinn NCC, you may begin your conference.
Thank you. Good afternoon, everyone, and welcome to the Disparities Learning and Action Network call. Today's topic is Driving High Performance for Chronic Disease Management Teams. I'm your facilitator, Nia Lindsay. Others who will help me facilitate include our event lead, Melanie Wasserman, our chat manager, Nora Sears, our call manager, Patty Nelson, live note taker, Hillary Ann Tower, and our operator, Kelly. If I get disconnected for any reason, Hillary Ann Tower will be our backup facilitator. This call will be 90 minutes long. In the first hour, we'll focus mainly on our speakers, and you can comment or ask questions in the chat box. At 4 p.m., we'll stop for a full 30-minute discussion with the phone lines open. We'll post a recording of today's session on the Healthcare Community site. The slides are already there, and Nora will post the link in the chat box. We ask for your full attention today, and we ask that you bring an open mind, be collaborative, join the discussion, be willing to share successes and challenges, and value each other's experiences. Today's topics, you'll hear how NYU and IPRO's Project Impact is helping low-resource practices to meet blood pressure goals in a South Asian population in New York City. We'll also hear about some resources from the CMS Office of Minority Health that can support chronic care management for persons with disabilities, patients with limited English proficiency, and patients who have dual eligibility for Medicare and Medicaid. Before we start the presentations today, let's get a sense of who's in the audience. Please answer our poll question. Which chronic conditions are you focusing on in your work? Click all that apply. If there are others, please enter those in chat. We'll give you a few minutes to complete that. All right. Nora, maybe you can summarize a few of the answers that we're seeing?
Sure. Hi, this is Nora here. So there were many participants who wrote their answers in chat before the poll came up, so thank you for your participation. I'm actually seeing quite a fair spread of all of the tasks, a lot of participants who are involved in A and C, but there is quite a spread across all of the tasks. I'm not sure if the poll results have come in yet.
Okay. All right, we'll give those a few minutes. So, as Nora said, a lot of you are working on diabetes and mental and behavioral health. And many of you also share more specific areas of interest when you register. It looks like the poll has the majority of you all focusing on diabetes, followed by hypertension, mental and behavioral health, and other. And some of those are listed in chat. So we'll cover as many of those as possible. And during the presentations, we can talk more in the chat box and during the open discussion. Next slide. So questions to run on. Thinking about the strategies and tools presented today, which ones are you already using and which ones would you like to try? Let's meet our speakers. Your speakers today are Nadia Islam and Jennifer Zanowiak of NYU, Joanne Vanterpool of IPRO, and Sonia Karpiak Bowen of the CMS Office of Minority Health. I'll introduce each one right before they speak. Our first three speakers will focus on project impact. Dr. Nadia Islam is our first speaker. She is an assistant professor in the Department of Population Health at the NYU School of Medicine. Her work focuses on reducing chronic disease disparities through culturally relevant community clinical linkage interventions. And you can read about her work in the American Journal of Public Health, Diabetes Care, and other peer-reviewed journals. Nadia, you have the floor.
Wonderful. Thank you. Good afternoon, everyone. I'm really pleased to be sharing our work today on advancing Million Hearts goals through integrated community health worker and provider models. Next. So I'm the research director and lead a core research project of the NYU CUNY Prevention Research Center. Our PRC is part of a network of CDC-funded applied research centers across the country. The mission of our particular center is to develop and evaluate effective and sustainable community clinical linkage models for chronic disease prevention in urban areas. We have several aims of the center to achieve this mission, which are outlined on the slide here. And our core project of the center is Project Impact, which I will be discussing today. Next. So I'll start off with a little background. Next slide, please. As many of you on the call know, there's a growing emphasis on models that more effectively link communities to healthcare systems to improve cardiovascular disease disparities. The Million Hearts Initiative is a CDC and CMS program that aims to prevent 1 million heart attacks and strokes by this year, 2017, and Million Hearts is continuing. And a cornerstone of this initiative is the implementation and dissemination of innovative linkage models that are evidence-based to improve blood pressure control. So the particular focus of our work in Million Hearts implementation is small primary care settings serving immigrant communities. And this is really for good reason. Both nationally and in New York City, there's a large proportion of small practices. Nationally, about 40% of people in the U.S. seek care at small practices. And in New York City, small practices largely serve immigrant and minority communities. Next. The community that we're engaging in our study are South Asians, one of the fastest growing minority groups in the U.S. In addition to their population growth, South Asians have a high burden of cardiovascular disease and develop hypertension at younger ages and lower BMI, yet there are really very few culturally tailored initiatives that are reaching this population. I understand that today's audience represents stakeholders from across the country, and though the work I'm presenting today is from a particular context, specifically small urban primary care practices serving a specific community, I believe many of our lessons learned will be relevant to providers serving other underserved populations, including rural communities, immigrant and minority communities, and limited English proficient groups. Next slide. Next. So Project Impact stands for Implementing Million Hearts for Provider and Community Transformation. And our goal with this study is to test the integration of two evidence-based strategies that are designed to improve hypertension control. So our intervention, our program as a whole, includes two components. The first is a health information technology intervention that includes training practices to optimize the use of their electronic health records to manage hypertensive patients through the use of registries to identify those patients and the use of alerts and order sets to better manage their hypertensive patients within the context of a clinic visit. The second component is the integration of community health workers into the clinical team at the primary care site. CHWs, as I'll refer to them throughout the remainder of the presentation, are trained lay health leaders that share common life experiences with the communities they serve. In our program, CHWs are responsible for leading group and one-on-one coaching of patients designed to improve hypertension management, connect patients to resources, and enhance self-efficacy for disease management and health promotion. We have several important partners in this project that are really critical to the implementation process and eventually really essential for sustainability and scalability of the project. First, we're working with Health First, which is the largest Medicaid payer organization in New York City, representing almost 1 million members. And they have a particularly strong penetration in minority communities and with small primary care practices. Health First has a multi-component role in our project. They're helping us identify practices to enroll them into the study. They are working on data acquisition through their claims data, and they're really key in our sustainability strategy. If we can demonstrate that this intervention works, there's an incentive for Health First as a payer organization to take on these initiatives in small practices. IPRO is another central partner. IPRO is New York State's quality QI organization, and particularly works with practices in our study to build their capacity to achieve meaningful use and PCMH status, as well as a host of other things. You'll be hearing from my colleague at IPRO, Joanne Vanderpool, shortly regarding their really critical role in our project. Next. So this is an overview of our study design. We have enrolled 16 practices into our study. And just broadly, the design of our study is that all practices receive the intervention and are phased into the project in groups of 3 to 4 practices at a time, and we collect pre- and post-intervention data that's analyzed across all sites. At all sites, the practices receive the electronic health record component of the intervention in the first year, and then the CHW component of the intervention after 1 year. Our primary outcome of interest is looking at individual and aggregate level blood pressure control at the practice. Next, please. So the results I'll be sharing with you today and talking about during my presentation are really focused on the implementation process of the first component of our program, which is the electronic health record-based intervention. I am going to discuss throughout how engagement of community health workers was really essential in all phases of our study, even the electronic health record component. The first part of our process was recruitment of sites into the study, and we used a multi-pronged approach to identify sites that met our eligibility criteria. We completed a practice assessment with a subset of 29 sites to really characterize the patient population, the practice staff makeup, their use of electronic health record, health coaching, and referral strategies. And then we enrolled 16 practices into the study. Next slide, please. Here I've provided an overview of kind of the overall workflow of our project. So after conducting practice outreach and practice assessment, enrollment of practices into our study entailed signing a memorandum of understanding where we kind of outlined the components of the program as well as the data that we would be collecting from sites. We established a protocol for baseline and regular data collection from the electronic health record. And then this sort of EHR piece of our intervention really launched, and that included conducting a baseline workflow analysis and a 3-day training to implement the EHR intervention. And then it was considered launched. We then engaged in regular technical assistance with the practices, and after a 12-month period, a team of community health workers led group and individual counseling sessions for the practices. Next slide, please. From our practice survey, we found that the practices that we are working with they're really low resource setting. So the EHR component of our intervention was designed to be simple and not resource intensive. It's outlined here. It includes a fairly short training period over the course of 3 days, which we usually conducted over a 2-week period. We then, as I mentioned, provided ongoing but as unobtrusive as possible technical assistance, and I think Joanne will tell you a little bit more about that in her presentation. And then we are also engaging in, this should actually say biannual data polls. Next. So just to give you a sense of who we're working with, here's some of the results from our practice assessment. So the quick snapshot is that, the practices that we are working with are serving a high-need population. You can see the high proportion of Medicaid patients, for example. And the practice assessment also gave us insight into practice constraints. For example, these are very staffed by very few individuals. They're quite literally mom and pop shops sometimes, these practices. And they're also fairly new to the use of electronic health records. Next. So today we've implemented the EHR component of the intervention in all 16 of our sites, and our early experience has shown us that the model is feasible and practical, really accounts for time constraints of practices. On average, the trainings have been about 4 hours. We've also developed a model that provides for ongoing technical assistance, which is really critical, and that's provided both in person and remotely via WebEx. To date, practices have received an average of 6 TA sessions. Next. And here I'm sharing some preliminary results of the impact of just the EHR component of our intervention on blood pressure control at the practice level. Now, this is only from a subset of our practices, and it's looking at baseline blood pressure control 6 months prior to the implementation of our intervention and 12 months after the implementation of our intervention. And you can see for most sites, blood pressure control is improving, which is what we like to see. Next. So we've identified several key challenges in doing this work, and those kind of fall into 3 main buckets. First, there are challenges in terms of the practice context that we're working in. So I've mentioned that these are low resource practices. This is in terms of staff, but it's also low resource in terms of things like time and money. And they tend to have a lower baseline knowledge of the use of electronic health records and EMRs for population health management. Second, in terms of the community context, we are working with practices that are serving almost exclusively an immigrant population. And so the inherent challenges of engaging immigrant populations are really relevant to this program as well. The patients that our practices are serving have long working hours. They are often seeking care without appointments, and there's a high number of walk-ins. And then even within the patient context, there's a lot of diversity, demographic diversity and diversity in English language proficiency. So our practices are seeing South Asian patient populations, but even within that one subgroup, this encompasses multiple languages and ethnicities. So counseling and health coaching needs are really challenging. So that challenge, I think, is really a real benefit in utilizing the CHW approach. And then finally, there's some key challenges faced in terms of partner contact. And specifically, I'm going to note 2 partners, both payers and the EMR vendors. For payers, what we found is that the utility of claims data does not always meet kind of research study needs. It's actually engaging in our project has required capacity building on the part of our payer organization partner to really pull and use their claims data for research purposes. And we've also found that vendor engagement is critical. So EHR vendors, even those that have a population health management kind of framework baked into their systems, are not really designed to meet the needs of small primary care practices that really require simple methods without a lot of additional add-ons or softwares to be able to achieve those goals. We're working across 2 vendors in our 16 sites, eClinicalWorks and MD LAN. As an example of this challenge, we found early on that EMRs are not set up to run hypertensive patient registries by control and uncontrolled status using the correct definition of blood pressure control. So to address this, we had to really work with each of the vendors to develop specific reports that were deployed to each of the practices. Next. So just some key considerations that our work has generated, and I think considerations for other groups that are doing work like ours. Practice engagement for these types of practices is complex. In-person contact is critical, but at the same time, I think practices are really hungry for these resources. A real selling point of our intervention was the multi-pronged nature, and from the outset, community health workers were part of our team, and being part of the engagement team and reaching out to practices has been successful. We were really able to paint a complete picture from the beginning for practices of how something like running a registry list to identify patients on the one hand can be linked to CHW health coaching efforts on the other. In addition, because a key element of the CHW model is that CHWs are from the target community, and because we're working in practice settings where providers are also from the target community, CHWs really facilitated practice engagement, helped to build the case for the need for this program, and mitigated linguistic and cultural barriers to accessing the site. In terms of programmatically, we have found the need to kind of balance flexibility with these types of settings, which is really key, but balancing that with the need for protocols, workflow analysis, and training manuals. So in doing this, we have created what we believe is a replicable, potentially scalable parts of our program, but that also consider context at the same time. And finally, in terms of health information technology considerations, we have developed a model that's EHR agnostic, at least across 2 EHR systems, but we're also learning that working with vendors is really crucial to the success of these types of projects. So the figure on the right outlines what we believe is a replicable model for practice engagement and kind of training and capacity building. Next. So the case study of our intervention was launched in March 2017, and to date has been implemented in 7 out of the 16 practices. It's very important that CHWs have already been part of our program. They were involved in conducting the workflow analysis and were part of the trainings and technical assistance that practices received, which has really allowed them to gain better understanding of practice context to develop protocols that are relevant to the practice setting. This is an overview of what our CHWs do. So they recruit patients with uncontrolled hypertension using registry lists, letters from the physician, and tabling and phone calls. They offer these 5 group sessions and follow-up phone calls, and then they offer feedback to the clinicians that are part of the primary care team. Next. So we have several early lessons to share on the CHW component of our program. First, we found that the practice facilitation component of the intervention really cues the practice for the CHW-led coaching. It brings into focus procedures and strategies to better identify, characterize, and follow up with the hypertensive patients. As an example, I didn't show this data, but we've seen across our practices that the proportion of hypertensive patients is increasing over time after implementation of the EHR training. And that's likely a result of better coding and documentation of these patients by practices. I've already discussed the second point around CHW engagement. We've also found that acceptability of the CHW model is high, and you'll hear more about that from our CHW program supervisor, Ms. Denaliak. Also, just going back to the poll that we took, I think these types of programs really sets the stage for practices to be able to use CHW models to address other disease areas. So building on this work around hypertension management, we're going to be establishing 2 new programs on diabetes prevention and diabetes management. There are challenges, including logistical constraints like space and timing. These practices are small, not only in terms of staffing, but, literally in terms of space. The ability to engage patients in group-based sessions is challenging. And the resource intensiveness of recruitment of patients into CHW coaching programs is high. We're really using a multi-pronged strategy, and the practice is very helpful in reinforcing the value of the program. Next. So we've developed many products that can be disseminated across payers, health departments, and other organizations. I just want to call the attention to a report that our center developed on the integration of CHWs into primary care practices. I know there are many questions on CHW sustainability, and this report provides case examples from across the country on various ways that this has been done successfully. Next and last slide. So I'd just like to acknowledge my study team, including our large team of CHWs and our funding source, and I look forward to our discussion. Thank you.
Thank you so much, Nadia, for sharing what you and your team have been doing with Project Impact with us. We'll move on to our next speaker, Nadia's QIO partner, Joanne Vanterpool. Joanne has been at IPRO for the past 8 years. As a senior clinical practice advisor, she assists practices with fully maximizing the use of their electronic medical health records. And with practice transformation, advanced primary care, patient-centered model medical home, and QPP mixed MACA as well. Joanne, you have the floor.
Hello, everyone. My name is Joanne Vanterpool, and I'm a Senior Clinical Practice Advisor at IPRO. I've been working with Nadia and her team for the past 2 years to provide technical assistance to practices enrolled in the EHR CHW intervention program. Next slide. For those of you who aren't familiar with IPRO is part of the federally funded Medicare Quality Innovation Network and is also the Quality Improvement Organization for the state of New York. IPRO leads the Atlantic Quality Innovation Network, which includes the Delmarva Foundation of the District of Columbia, as well as the Carolina Center for Medical Excellence in South Carolina. The AQUIN is one of 14 Medicare-funded QIO operating across the U.S. Next slide. As a recognized leader in improving healthcare quality, the AQUIN provides innovative services and solutions to create healthier communities. We catalyze change through a data-driven approach to improving healthcare quality. We work with providers and stakeholders at the community level to share knowledge, best practices, and improve care integration. As part of the National QIO program, we are committed to a patient-centered approach to improving healthcare, and reducing costs for all Americans. Next slide. IPRO has been working with Project Impact since 2015. It's been a great privilege to work with Nadia and her team. Nadia and her team have put together a very structured EHR CHW intervention program that supports the practice by assisting them on the best ways to maximize the use of the electronic medical record to make workflow easier and more efficient for the practice. We analyzed the practice's workflow to identify the best ways to introduce interventional tools for blood pressure control. These interventional tools could be as simple as setting up order sets, running registry reports, using templates, setting up alerts, or even showing the practice how to use their patient portal. Our goal was not to disrupt the practice's workflow, but to help them use these additional tools to improve the current workflow. We also provide efficient strategies for incorporating the EHR solutions into the practice, while at the same time showing practices how to improve blood pressure control and cardiovascular health. Many of the practices that I initially encountered were not using the EMR the way it should be used. That's because they were not aware of some of the functionalities of the EMR. Some of these practices have now adopted some of these new features into their practice's workflow, and the evidence of this is seen by how their data has improved. Next slide. IPRO provides technical assistance to Project Impact by assisting practices with capturing data on blood pressure control via structured data fields and registry reporting. We also assisted Project Impact with the practice-level aggregate data extraction for the benchmark reporting period by pulling the data needed to do assessments on the practice prior to providing them with interventional tools. Our TA is aligned with our deliverables for the 11th scope of work because we help practices collect data for the ABCS metrics, and we provide them with data analysis and feedback on how to get patients to effectively manage their blood pressure, and also how to get patients to be engaged more in their overall health. We provide education and assistance to NCQA patient-centered medical home, and we assist the practice with practice transformation. If asked, we also provide blood pressure measurement, management, and quality improvement training to the office staff. We offer sessions on motivational interviewing, and we also assist the practice on the various federal incentive programs like Meaningful Use for Medicaid practices and the Quality Payment Program for Medicare. Next slide. My site visits consisted of training practices on the EHR functionality to record structured data for meaningful use. I would review the annual reports to see if they met the benchmark on the objectives. When I initially started working with these practices and I pulled their meaningful use reports, the vast majority of my practices were not doing too well. I found that a lot did not understand or know the capabilities of the EMR or where to put the data. This project actually allowed me to work with these practices to show them how to improve their benchmark data so that they could successfully attest for meaningful use in 2016 and get their data ready for 2017 submission. I also assisted practices in pulling data for the cardiovascular health. I would show them how to pull reports from the EMR, how to track their hypertensive patients, how to engage patients in their health through patient outreach, using the reminders, the alerts, the electronic referrals, accessing the patient portal, and also looking at their RX formulary checks. I also educated practices on patient-centered medical home. Any practice that was interested in PCMH participated first in an informational session. If they decided to participate in PCMH, IPRO would assist them after conducting a practice assessment. My site visits weren't only training the clinician, it was also training the office staff to ensure that everyone was familiar with the capabilities of the EMR. Next slide. When working with a practice on a new project, there are usually a few barriers that the practices have to overcome. One is not knowing the capabilities of the EMR. This is a barrier for a lot of practices, because if they knew how to use the data in the EMR this can actually simplify their workflow. For the most part, a lot of the practices have limited knowledge and the capabilities and use the EMR only for the day-to-day operations of the practice. So the learning curve of introducing them to these features and having them incorporated into their day-to-day operation. Pulling the aggregate data was also difficult because each EMR has a different reporting capability. Some reports have to be customized by the vendor. We could still pull reports via the registry or the CAN report for the purposes of our project, but some customization had to be made in order to get accurate data. Another barrier was patient engagement. The population that we serve is not very compliant when it comes to blood pressure management. These patients are not compliant in taking their medications and coming back for follow-up care. In my conversations with some of the practices, patient engagement was one of their top concerns. Another barrier was the patient's reluctance to engage, the practice's reluctance to engage in virtual visits. My practices felt better if they had me in their office pretty much every week. In the beginning of the intervention, I would see them at least maybe 2 to 3 times a month. However, after training and working with them on the capabilities of EMR and helping them meet their meaningful use benchmark, we're able to limit my site visits with them. But I still have a majority of practices who do still want to see me at least once a week. Next slide. We aligned our EHR intervention with the Medicaid meaningful use objectives as well as the patient-centered medical home standards for 2014. Listed on the slide are the meaningful use objectives that align with Project Impact. Objective 1, which is the clinical decision support, and Objective 6, which is the patient education. Both of these objectives are met by training the practice on how to set up the CDSS alerts and the custom-made point-of-care alerts, and also showing them how to use their order sets that are necessary to upload, disseminate, and build for patient and cultural payload education. Next slide. For NCQA PCMH 2014 recognition, I demonstrated how NCQA standards listed on the slide align with Project Impact. I would go over the standards with the practice and show them how Project Impact EHR CHW intervention would allow them to successfully report on these various standards. For the 2017 NCQA PCMH, the standards have changed. So for 2017, NCQA has placed more emphasis on improving focus and flexibility, support of continuous practice transformation, and providing more comprehensive integrated care. We have aligned the 2017 NCQA PCMH standards for Project Impact for the practices to meet the new standards. In conclusion, a lot of my work with Project Impact has been greatly appreciated by the practices that I assist. I've become a very valuable resource to these practices to help them with the EHR CHW intervention. And it's been great watching a lot of these practices from where they started to how they're progressing now and being able to report better numbers for meaningful use. Thank you for allowing me to speak to you today. I now turn over to Jennifer.
Thank you so much, Joanne, for sharing with us your experience in providing TA for those practices. I'm sure our audience members will have some questions for you when we get to the Q&A section. As I mentioned, now we'll go to Jennifer. Jennifer is our last speaker from the Project Impact team, Jennifer Zenowiak, and she's an experienced research coordinator with a focus on addressing disparities in chronic disease prevention and management. Today, she'll share with us her experience supervising community health workers for Project Impact. Jennifer, you have the floor.
Thank you. Good afternoon, everyone, and thank you for inviting me to be a part of today's discussion. I have worked with Dr. Islam at the NYU School of Medicine since 2017 on community health worker-led health interventions across several New York City Asian immigrant communities to address diabetes and cardiovascular disease prevention and management. As Dr. Islam discussed, The standard format for a health intervention is a series of CHW-led, group-based education sessions delivered in the participant's preferred language with follow-up phone calls using motivational interviewing techniques to improve health behaviors. I have a brief presentation today and have been asked to discuss my responsibilities as a CHW supervisor, what a typical workday is like for a community health worker at our center, how we foster good relationships between our community health workers and the primary care team, and how we support and engage our community health workers. Next slide, please. So you can see here some of our community health workers in the photo on the right. And then the photo on the left is a photo of one of our sessions. Our community health workers are leading the participants through a kind of series of exercises, low-impact exercises. So as a CHW supervisor, a few of my major responsibilities are hiring, training, and development, ensuring fidelity to the research intervention, and troubleshooting challenges. Regarding hiring, we found that the most successful CHWs are well connected in their communities and may have had some previous experience with community advocacy and or social services and social work. They have a strong desire to help their communities and are truly empathetic. Often they are immigrants themselves and are familiar with the challenges and struggles our participants face navigating new and unfamiliar institutions. They know how to read people and build trust. They understand cultural norms and practices and can relate to participants in a culturally sensitive and culturally appropriate manner. Because of these qualities, they can provide tremendous insight to successful implementation of research, interventions, and health programs in our target communities. Once a CHW is hired, we provide them with a CHW core competency training developed in partnership with the CHW Network of New York. This training is intended to build skills and confidence of the community health worker and provide a contextualized view of client needs and the role of the CHW. In addition, I provide trainings on study protocol and timeline, data collection, and other research-related topics. Many CHWs do not necessarily come with experience in documentation and data collection, so these are important skills to focus on for the project. I am also responsible for ensuring fidelity to the intervention. This includes tracking the project timeline and delivery of health education sessions and phone-based health coaching as per the protocol. Often this involves troubleshooting challenges. I monitor participant recruitment and engagement after they're enrolled closely and work together with the community health workers to identify alternate strategies to address challenges as needed. A typical workday for a project impact community health worker varies depending on the phase of the project. Our CHWs are involved in practice engagement and partnership building, patient recruitment, engagement, and retention, providing health education sessions and phone-based health coaching, referrals to social services, translation and interpretation, and data collection. Community health workers spend a lot of their time out in the field, whether they are engaging new practices in the project, facilitating trainings on the EHR between the staff and the EHR trainers, serving as a liaison between the practice and the researchers, and making themselves available for sessions and coaching at the clinic site. They may visit community institutions such as faith-based organizations and community centers to recruit participants, or try to build relationships to better connect their participants to community, social services, or health services. They also spend a lot of time making phone calls, whether they're scheduling technical assistance sessions, recruiting new participants, scheduling existing participants for education sessions, or making phone calls to work with patients on their health goals. A good amount of their time is spent fostering good relations with the primary care team. We use several strategies for this. First, it is very important to get buy-in from the office staff. We hold training and orientation for office staff on the goals of the project and roles of the CHWs. We also invite them to sit in on health education sessions to see for themselves the benefit to their patients. We involve them in recruitment by asking them to refer patients who meet the study criteria who come in for office visits, and we provide them with our business cards and flyers. Our CHWs also go out of their way to provide assistance to the office staff that is outside of the research. For example, our CHWs provide office staff with translations of patient notices as well as updates to patient contact information. Our CHWs often get more current address and phone information for patients during the course of the intervention, and the offices always appreciate getting this information from us. Our CHWs also facilitate appointment keeping. Since they often have more regular contact with the patients during the course of the intervention, They asked about upcoming appointments and encouraged participants to go to them or provide assistance getting to appointments when needed. Our community health workers have attended doctor's appointments with participants, particularly if they're going to see a new doctor or a specialist. Finally, the progress notes on patient participation. They notify doctors immediately when they take blood pressures in a very high range and provide regular updates so providers know how their patients are doing. The last item I wanted to talk about are the ways we support and engage our CHWs. Our CHW positions are paid, not volunteer positions, with competitive salary and benefits, including for part-time CHWs. It is important to note that at this time they are all grant-funded. However, as Dr. Islam discussed, an important component of this project is to determine how we can work with payer organizations for reimbursement of CHW services. As I discussed earlier, we provide extensive training and professional development opportunities. I hold weekly team meetings to discuss the status of the project at each of our clinic sites. During these meetings, our CHWs are engaged to provide insight about what works in the community and how to improve our research protocols and procedures. Also, we know the value of peer-to-peer learning and so support our CHWs in attending networking meetings with other CHWs. And we also support a train-the-trainer model in which senior CHW staff help train new CHW staff. Our more experienced community health workers have a wealth of knowledge to share about tactics for participant recruitment and engagement and provide important feedback about delivery of education sessions and health coaching. Finally, we include our CHWs as authors in publications and presentations and often co-present on our projects to ensure that the CHW perspective is represented. I hope this provides an overview of our CHW experiences, and I'm happy to answer questions later during the Q&A. Thank you again.
Thank you so much, Jennifer, for describing your work with community health workers. Right now, we'll stop here to receive and answer a few questions on project impact before we hear from our last speaker. Nora, are there any questions or comments in the chat?
Hi, Naya. Yeah, thanks for asking. So earlier on, we start with the first question posed by Sarah Landy to our speakers, and she asks, what are the demographics, specifically ages, types of comorbidities, and disabilities of the patient population included in the program?
So thank you, Nora. That's a great question. This is Nadia. In terms of demographics, age groups, comorbidities, and disabilities, so I do just want to note that this is a research intervention that we're testing. So we have some particular eligibility criteria that we have patients meet to enroll into the CHW component of the intervention. So that includes patients from ages 18 to 80 who have a diagnosis of hypertension and have had an uncontrolled hypertensive reading within the last 6 months. So that's kind of our broad eligibility criteria. And in terms of the patient population at these practices more generally, data from our practice survey has shown that this is largely a Medicaid patient population. There's very high rates of both hypertension and diabetes, and unfortunately we haven't been able to look at disability status.
Thank you for that feedback, Nadia. It looks like we have another question, Laura.
Yeah, hi. We had one question from E. Kaiser, and she's asking, what role did the CHW play with self-management education within the IMPACT program?
Thank you. I think I talked about this a little bit. So our community health workers provide in-language group-based education sessions on a series of topics related to high blood pressure. So we have 5 monthly sessions about blood pressure, healthy diet, physical activity, and stress management. We also talk about the risk factors for cardiovascular disease. So we talk about cholesterol, blood sugar, and smoking. And then finally, we talk about communication with doctors and improving access to health care. So those are the group-based education sessions that are once a month. And then we also, the community health workers provide biweekly phone follow-up calls where they're working on setting short-term and long-term goals with the participants about changing their health behaviors. So they work with them on, a healthy diet goal for a couple of weeks, and then they might gradually, increase the goals. They might also include physical activity goals where they're working on getting participants to increase their physical activity level. So there's lots of different things that they're working with them on during those phone calls.
I just want to add that medication adherence is another piece of that for blood pressure, both in the goal setting but also as part of the overall curriculum.
Okay, thank you both. It seems like the community health workers are really engaged in trying to improve the health care and the health status of these patients. All right, so we'll take additional questions during our open session shortly. Before we do that, we'd like to go to our final speaker. Her name is Sonia Karpiak-Bowen of the CMS Office of Minority Health. Sonia has been at CMS for more than 20 years, joining its Office of Minority Health in 2015. Her work has focused on increasing physical accessibility in healthcare settings, analyzing and better meeting the needs of Medicare and Medicaid eligible populations, and supporting culturally and linguistically appropriate services in nursing homes. Sonia, you have the floor.
Hi, thank you. Can everyone hear me?
Yes, we can hear you.
Okay, great. So my presentation is looking more at big picture considerations for providing chronic care management services to people with disabilities, people with limited English proficiency, and people who are dually eligible for both Medicare and Medicaid. And I'll be highlighting a number of resources that are either available online or will be available soon, and there will be links. There will be links within the presentation on where to find some of those resources and emails on where people can go if they have questions. But first I wanted to tell you a little bit about CMS's Office of Minority Health, our mission and vision for promoting health equity, and different pathways for addressing health disparities within healthcare programs, which would include chronic care management. Next. So as CMS is developing, implementing, and evaluating all of its many programs, CMS OMH's role is to make sure that the voices and needs of racial, ethnic, sexual, and gender minorities, rural populations, and people with disabilities are represented. In our role, our guiding principles are to eliminate disparities in healthcare quality and access, and for all CMS beneficiaries to be able to achieve the highest level of health possible. Next. Here is the Path to Equity, which is the framework that we use to guide all of our work. And the resources that I'll be sharing with you today and touching upon, they touch upon all three domains that you see here in the Path to Equity, which are increasing understanding, disseminating solutions, and implementing sustainable actions. Next. So real quickly, what is a healthcare disparity? I'm going to give you a Cliff Notes version of a healthcare disparity, and this is borrowed from the 2002 Institute of Medicine study entitled Unequal Treatment. So here you have Group A, that represents folks who are receiving optimal quality of care and having optimal health outcomes. And then you have Group B, who's having a lower, having worse outcomes or quality of care. And to break that down, there are different factors that play into that difference. And just in short, what a health disparity is are potentially avoidable differences in health between groups of people who are more or less advantaged socially and economically. And this includes differences in access to care and quality of care. What I'm going to do here is zero in on the center, the second factor that's in the middle, the operations of healthcare systems and the regulatory climate. What I'm trying to get at in sharing resources are what are those operational and programmatic areas that providers can
impact to make care more equitable. So why are we highlighting patients with disabilities and people who have limited English proficiency and dual eligibles in the context of chronic care management? While for persons with mobility or sensory impairments, physically accessible clinical settings, medical equipment, and services are critical to the delivery of effective chronic care management services. As an example, if your practice does not have the appropriate equipment or staff training to accurately weigh a patient who uses a mobility device, you're going to have a lot of problems calculating an accurate prescription dosage, which can then in turn domino into other clinical problems, which of course we don't want. We also know that good communication between patients and providers from the administrative staff all the way up to the clinicians is essential to providing high quality care. So what we're talking about here is programmatic solutions to make sure that people with visual or hearing impairments or people with language barriers can understand and fully benefit from a chronic care management program. And thirdly, duals are important to this conversation because compared to Medicare-only beneficiaries, we know that duals are more likely to have multiple chronic conditions, they're more likely to have a mental or cognitive condition, and they're more likely to have functional impairments. So this is why we're kind of highlighting these populations here. So, and what you see here in this table, we're borrowing from an article on persons with disabilities as an unrecognized health disparity population that was published in the American Journal of Public Health. And the data, and I'm not going to go into the data specifically because you can look at it, but the data in the table reinforce why we need to think about healthcare consumers with disabilities, whether they're Medicare only or they're duals when designing and implementing chronic care management programs. So as you look across some of the indicators that are listed here in the different domains, there are other healthcare indicators that are not included here, but what you see consistently across the board is that people with disabilities fare worse. Next. So here are the six CMS priorities within the plan for improving equity in Medicare. And all 6 of these priorities are relevant to improving chronic care management, and more information on each of these priorities is available on CMS OMH's webpage. But for today, we're going to be focusing on resources that are available through the last 2 priorities, Priority 5, improving communication and language access, as well as Priority 6, increasing physical accessibility of healthcare facilities. Next. So we have some communication and language access resources to try to help address some of the issues that I was talking about previously. We have an issue brief that's out now on understanding communication and language needs of beneficiaries that's looking at both people with limited English proficiency as well as people with disabilities. And the website is there as to where you can access that issue brief. And there are also a couple of additional resources that are coming soon. One is looking at a provider survey on how healthcare providers can meet patient language needs. And then our office has a series of resources called Building an Organizational Response to Health Disparities. And coming up soon will be a guide to developing a language access plan. A lot of providers know that they need a language access plan, but don't know what that means or how to do it. And so we have a resource that will help with that process. And then also within that series, there will be a resource on approaches to providing communication and language services to diverse populations. So be on the lookout for that. Next. Under our priority on physical accessibility, we have an issue brief on the CMS OMH web page that is a really good primer on physical accessibility in healthcare settings and actions that are being taken at the local, state, and federal levels to remove accessibility barriers. And then we also have resources that are under development right now for both providers and for program beneficiaries, and there are two in particular that will be available soon in the coming months. One is a provider toolkit on removing barriers and understanding patient accommodation needs that will help answer the question for providers, what do we mean by accessibility? What steps can providers take to make the clinical setting more accessible? And then we'll also have beneficiary education materials for working collaboratively with providers and administrative staff on requesting and getting needed care and understanding what their accommodation rights are. Before we move on, I just wanted to highlight really quickly from the provider toolkit, there are two sources of tax relief through the IRS that are available to offset accessibility expenditures that are associated with barrier removal and alterations, and this would include equipment purchases and also accessible communication formats for interpreters. Very quickly, first, there's a tax deduction that's available for all businesses for barrier removal and alterations with a maximum deduction of $15,000 per tax year. In addition, for small providers, there is a small business tax credit that covers 50% of eligible access expenditures up to $10,250 for that particular tax year. So if you want more information on that, you can go to the IRS website and look up those two resources. Next. I wanted to mention the Right Now tool. The Clean QIOs have a means through the Right Now tool that's available on QualityNet to ask for technical assistance that's related to health disparities, and this is including but not limited to chronic care management. So within the tool, there is a topic area for health equity technical assistance, and it's kind of pointed out here. So you can look for help there, and if it's not something that we help with, we will definitely get you to the right resource within CMS. So please take advantage of that. Next. We also have resources through CMS's Medicare and Medicaid Coordination Office. They provide technical assistance and practical resources for providers for meeting the care needs of people who are dually eligible for Medicare and Medicaid. And here we have some examples of provider tools that are available through the resources for integrated care that comes out of that office. And these resources are designed to help health plans, health systems, and healthcare provider organizations to strengthen their efforts to provide integrated coordinated care for dual eligible beneficiaries. Next. Last but not least, the Connected Care campaign is an interagency federal campaign that CMS is a part of that launched this past spring to raise awareness on the benefits of chronic care management programs to both healthcare professionals as well as healthcare consumers, and particularly in rural areas and among racial and ethnic minority populations. And this online Connected Care Resource Hub provides a rich data resource for healthcare professionals who are designing and implementing chronic care management programs, and this would include how to bill for those services and also how to explain chronic care management to patients. So definitely check that out if you need resources and how to get started with that. And that concludes my presentation. Thank you very much.
Thank you so much, Sonia, for that helpful information. I saw a few comments and questions come in during your presentation, and we want to get to those. We also have a few others for our speakers before you. Before we do that, I know some of our attendees may need to sign off. So before we move on to the open discussion, would you all please answer one quick question to help us improve our calls? To what degree do you agree with this statement? I would recommend an event like this one to a colleague. You should see the poll question come up on the right side of your screen, so just click your answer. We'll review those responses. And also, please feel free to add any explanations in the comment box. Whatever feedback you may have, good or bad or mixed, will help us to improve. There'll also be a longer survey that pops up when you close out of the WebEx, and that one is anonymous. It would really help us if everyone would fill out that survey right after this call so that we can get more detail on what we're doing right and how we can improve. And again, the survey that pops up after you close out is anonymous. So thank you everyone for your responses. I'll briefly go over our upcoming calls and how to submit questions and comments, and then we'll open the phone lines for our peer-to-peer sharing session. So we do have a call to action before we move on, and that is for you to identify what strategy you heard today that you can implement immediately. And you can go ahead and post that in chat. Next slide. All right, for our future topics, we want to hear from you. Do you have a need or a desire to hear about a certain topic? If so, you can submit your ideas in chat, or you can email the Quinn NCC at the email address that's showing up on your screen. Next slide. And we have a few events that are coming up. On October the 11th, we have a medication safety LAN event. This is a review of patient activation and prescription drug monitoring, resources to enhance medication management with patients. Registration is required using the link shown. And then on November the 8th, we have a national LAN event. It's entitled Engaging Physicians and Care Teams to Prevent and Manage Diabetes. And registration is also required for this event as well. Next slide. All right, it looks like this is our peer-to-peer sharing portion, and I will turn to Nora. Nora, do you have any questions or comments in the chat?
Yeah, thank you. So we had a couple that we're waiting to be addressed until now, and we had one from Jennifer Sanderson who asked, with patient engagement being a barrier, what are some things that work to help promote patient participation in the program?
Thank you for that question. This is Jennifer. So we have several strategies that we use to increase participation. First, we send a letter from the provider and an in-language flyer, and the letter basically says that, we have this great program that's available to you. We think that you may be interested in it. Please contact the community health workers below. And then we also have a flyer there where we have a nice picture of our community health workers with kind of a brief description of what the program is all about. We also schedule multiple sessions throughout the week at multiple times, and this includes Saturdays. So we kind of have sessions 6 days a week to make sure that our times are really flexible and accessible for patients who have various types of work-life schedules. We also hold our sessions at various community-based locations in addition to the clinic site. So we try to reach out to local community centers and sometimes the local libraries to see if we can hold sessions there. Sometimes this makes it a little easier for participants to be able to come out to the sessions. And also, as I've mentioned before, for patients who have trouble physically making it to sessions, we try to find ways, if possible, to either accompany them to a location to show them how to get there. We also provide Metro cards, one-way and two-way Metro cards, so that they're able to get there and back at no cost to them.
Okay, thank you. That's very helpful. Laura, any other questions?
Yeah, we have a couple here. So the first one is from Anne Engelhorn, and she asks, are there any educational requirements for the CHWs that are performing these duties?
So I'll address this question. This is Nadia. So, what we think is critical for a CHW is a close connection to the communities they serve. And so I think successful recruitment of CHWs really happens from the job description, point of things. And so we've really built into the job description a pretty comprehensive list of the types of attributes and qualities that we're looking for, and then we really leverage our community networks to find individuals who are community leaders in the target communities where we're working. In terms of educational requirements, we have included having a high school or GED as an element in our job description. However, I will say we have hired CHWs that don't have that, and we've actually worked with our institutional human resources department to kind of negotiate with them and make the case for why other characteristics of CHWs are more critical to their success. And then, once on the job, we train our CHWs. As Jennifer mentioned, they go through a standardized core competency-based training that we deliver in partnership with a citywide CHW organization. And then we supplement that with kind of protocol and other trainings relative to the projects they're working on.
Oh, thank you for that feedback, Nadia. Before we go to the next chat question, I wondered if Kelly, if you remind everyone how to submit a question to the phone line.
Sure. If you would like to ask an audio question, please press star followed by the number 1 on your telephone keypad. Again, that's star 1 from your telephone keypad.
Thank you so much, Kelly. And now we'll go back to Nora for the remaining chat questions. Nora?
Great. Thanks, Diane. So we have one comment from Deborah McCall, and she was wondering if it was appropriate if you could address the problem identified in the results presented to CDC, NCC, DPHB staff from a Don't Miss Million Hearts program within the first couple of years. Are you familiar with this, or would you like to address this in a follow-up email?
This question is for all the panelists?
I believe so. Deborah, if you're on the line, if you would like to call in to explain this, you are free to feel free to do so.
And if she's not, I can just start to give an answer from our perspective. So we, in terms of blood pressure equipment and calibration, we didn't have the capacity to be able to standardize the equipment across the practices that we're working on. And, this was designed as a pragmatic trial. So we're, and as I mentioned, we're working with low resource settings. So, having standardized equipment across the practices wasn't something that we did. However, what we did do actually in partnership with iPro is implement a blood pressure screening protocol at all the practices, and that included a train-the-trainer model of how to take blood pressure measurements correctly, and all the team of the practice members were trained in that. I don't know if Joanne wants to speak to that any further.
Joanne, did you have anything to add?
Yes. The problems that we had in the beginning of the project really was just helping the practices understand the EMR and what the EMR can do for them. That was the issue because a lot of the practices, they did not know that the EMR had all these capabilities for them and that it can simplify their work. So that was one of the biggest things that we saw when we started working with them. Now I can tell you that a lot of my practices now have incorporated these, some of the training that we have provided to them. And when I look at their meaningful use reports, especially for the 2016 submission, their numbers look really good because now they know exactly what structured data fields they can use, how to, and they also, a lot of them now know how to run reports on their patients through the registry so that they can send letters to their members. And so it's been a change right now that I've seen with the practices, and a lot of them are very happy because of the intervention that they're able to now incorporate these new changes into the practice.
Oh, thanks so much, Joanne. Nora, are there any other questions in the chat?
Yeah, there was one from Vista Georgis who was wondering if If you've ever had a situation having trouble recruiting and engagement CHWs, if they are not provided payment. This is part of one of the conversation via chat, but that is the summary of the question.
Sure. So I'm happy to address that. So we feel pretty strongly that CHWs have a professional identity. And I think, recent efforts are really revolving around integration of CHWs into clinical teams, which means they're really part of clinical teams. And so I think starting off in a place of CHWs being volunteer workers it's a difficult sell, to engage the model and to really elevate the value of the model. But I certainly understand the resource constraints. I guess one suggestion I would have is, I think that there are opportunities now with Medicaid expansion, and this is being done successfully across the country, to reimburse CHW services. What we're trying to do through Impact and really to develop a plan with the payer organization that we're working on is to think through what the different reimbursement models could look like. So in the context of like ours, where we're working with this network of small primary care practices, could CHWs be a shared resource that all of the practices kind of pool resources into? Could Health First as a payer organization support CHWs as part of their organization? And so I think we're still in the process of determining what the best kind of model is and what the most feasible model is. But I think keeping effective CHWs engaged as volunteer workers is very challenging.
Thank you. And Jennifer, I just wanted to go to you because you mentioned during your presentation that some of your CHWs were funded through a grant. Did you maybe want to tell us a little bit more about that for those individuals that are looking for ways that they can fund their programs?
Oh, sure. So Project Impact is a CDC-funded project. So we actually are employing our CHWs here at NYU School of Medicine, but the salaries are grant-funded. I'm not sure.
Yeah, and I think I can add to that. So on this project of CHWs are grant funded, but I think we've also tapped into other mechanisms to support CHWs based on their reach into the community. So, for example, with enrollment into state-based health insurance programs, a group of our CHWs serve as facilitated in-person navigators for the New York State Health Exchange. And that offers opportunities for them to reach out to community members to enroll them into health insurance programs, but also to engage in some of this chronic disease management work that we've been discussing today. Similarly, because NYU has a hospital system, they have what's called a community service plan. Hospitals across the country have this. And many of our CHWs are supported in part by our community service plan, and offer service. Part of their work is offering services back into the community districts that our hospital is serving.
Okay, that's helpful. I'm going to stop right here and go to Kelly. Kelly, do we have any callers in queue?
There are no audio questions or comments at this time, but again, it is *1 from your telephone keypad.
All right, we'll go back to you. Nora, do we have any other questions in our chat?
Hi, Nye. Yeah, there are currently no questions in the chat. I guess we did get one from Marie just right now. Is there sustainability piece in everything that is being done in New York for all 3 programs?
All right. Not sure who would like to take up that question about the sustainability piece. Nadia or Jennifer, perhaps you can talk.
Yeah, so I just want to make sure I understand the three programs. I think the caller is referring to IPRO's work and to the impact work. I think there's a few different ways to think about sustainability. One is sort of the big picture sustainability in terms of reimbursement, but I think all of the components of our intervention were designed with sustainability in mind. So for the EHR component, enhancing the capacity of the practices to be able to engage in this type of EHR work was really a key piece of the training. I think we've already discussed with the CHW piece that we are engaging in sustainability planning after the grant is over. And for IPRO, I don't think I can speak to that, but I don't know if Joanne wants to add anything to that.
Right now, we're hoping that these practices continue to work with us on any of the other initiatives that come along, and they seem that they are willing because they're seeing that IPRO is here to provide them with training on the EMR, as well as to assist them with any of the federal incentive programs that come down the line. So we're hoping that this transitions to a longer relationship.
Okay, thank you. And it's any of the participants on the call want to share with us in chat how you all are funding your CHW programs? That would be helpful, and perhaps we can discuss that a little bit more as well. In the meantime, I know some of you may have additional questions that you're typing in now. And I'll just ask Nora again. I had a few of my own, but Nora, do we have any more questions in chat?
We do have one question from Deb, who is wondering if there's information available for resources to add scales to a practice for wheelchair parents or patients, and also equipment for dental offices to treat wheelchair patients. If you have any insight on that.
I'm not sure, Sonia. Would that be a question you could take? I know you mentioned some of the resources for barrier removal.
Hi, I was actually writing something in the chat box when that question came through, so I'm just reading what this is. There are different kinds of resources available. There are, through the Americans with Disabilities Act, there are regional centers that can help with technical assistance. There are different resources that are available through different federal websites. One is the Department of Justice. And I don't have anything specific I can point you to, but Department of Justice, the Administration for Community Living, the Department of Health and Human Services, Office for Civil Rights. They each have websites that can kind of answer a piece of the puzzle on how practices can go about assessing where the needs are, like where kind of basically doing like an accessibility assessment, and then coming up with a plan on how to incrementally address any of those issues, because each of them, of course, have costs associated with them. And then when we have our toolkit, our provider toolkit, when it comes out, it kind of gives a framework for how practices could go about this process. But there are definitely existing resources that are available that can be found online. And I do want to mention, for this question and for any other questions that relate to health equity, we had mentioned the resource for ClinQIOs, but there's also a general, we have a general mailbox to CMS's Office of Minority Health that's available to anyone. Should you have questions or need to be pointed in the right direction, and that is healthequityta@cms.gov.
health.hhs.gov.
Okay, thank you, Tanya. And I believe we'll be able to share this information with participants outside of the live notes as well, and Nora has posted it in the chat box. In addition to that, and again, if anyone would like to call in, Kelly, would you remind us one more time?
Or if you would like to ask an audio question, it's star 1 from your telephone keypad.
Okay, and while we wait for any other questions that you may have, I'd like to ask a few that came up during your presentations. This one is for Nadia. Nadia, you mentioned that Health First, the payer group, was a integral part of your work. I was wondering, how did you develop this relationship? And if you had any tips for working with EHR vendors as well. That's the second question.
Sure. I think the second question could be a presentation on its own. Maybe a 3-hour webinar on its own. But I'll address that second and start with our partnership with Health First. So in terms of how the partnership was initiated, I think it was a combination of the fact that, I think as I mentioned, Health First is the largest Medicaid payer organization, and they're actually fairly good as a payer organization of engaging communities, and I think they do a lot of that in partnership with the small practices that they work with. And so I had had some experience working with them on some forums and other things that they put together in terms of engaging minority communities. And when this grant opportunity became available, we just actually met with them and to discuss the model that we were interested in developing. And I think they had some previous experience with some care management models. And I think it was really a combination of their past experience, their engagement in the community, and really, some pretty visionary leadership, I think, from the Health First Clinical Partnerships team. They have some leadership with Dr. Susan Bean, who's a partner on our project and is really very committed to models like these, and to bringing our work back to the Health First leadership to see how they might be able to inform sustainability. So yeah, and they've been really a central partner in every step in terms of practice engagement, and then with the data piece of this, sharing data with our research team, including claims data as well as Health First member data on blood pressure.
Okay, it seems like they were already kind of invested in eliminating health disparities, and you guys just teamed up to make a great match.
They were, and I think that with Medicaid expansion efforts, this is what some of the expansion efforts are really tasked to do, is to think about ways to address population health and integrate population health management into clinical settings. And that, I think, just necessitates going outside of the clinic. You can't do all of that just within the clinic. And so I think they had an interest in this for that reason as well.
Okay. Any quick tips for working with EHR vendors?
Sure. So actually, when I first started to put together this presentation, I had an entire slide actually on how we engage both eClinicalWorks and MD LAN around this issue of running a registry report that really is accurate, so because I think what the sort of baseline EHR is set up to do is to generate a report of patients who are coded as hypertensive. But what it's not set up to do is to identify patients who have a systolic of over, a certain level and or a diastolic of over a certain level. So really correctly identifying controlled and uncontrolled hypertensive patients. And so I think in each case with each vendor, we had to use a different approach. With ECW, they have kind of reporting structures and reports that you can build, but they are really built by the vendor that can be then deployed at each of the practices. So with ECW, it's something called an EBO report. So we actually worked with them iteratively to develop a report that would meet our study needs, but it was important for us, and this goes back to the sustainability question earlier, that this has been a report that the practices have that they can use to, to keep track of their uncontrolled hypertensive patient. And so we're actually just in the process of doing that now. We've done it successfully at one ECW practice and are going to deploy a similar report at the remainder of our ECW practices. With MD-LAN, we used a different approach, and that was that they kind of pulled the data for us directly from their dashboard. So we sent them the parameters of the kind of the data that we were looking for, and they sent us the aggregate blood pressure control and uncontrolled data per site. So in those cases, it does require resources. Which we had some resources built into the grant. I think the challenging thing is, obviously these types of small practices do not have these resources. And so I think the only solution to this is kind of continued engagement with vendors to help them understand that these kinds of small practices shouldn't be left out. Even in our, we're one small project, and even in our negotiations with each of the vendors, we were sort of able to negotiate the pricing on these types of reports. And so I think maybe there's an opportunity to do that at a larger scale. So I guess those are some brief tips.
Okay, thank you. It seems like it's more vendor specific, and it's important to also have a good relationship with your EHR vendor as well.
Right.
We have a few minutes, so I'm just going to ask Nora and Kelly if we have anybody in queue that has a question or anything up in chat.
We have no audio questions at this time.
Thanks, Kelly.
And this
Nora?
is Nora here. We do not have anything else in chat either.
Okay. I have one quick question before we wrap up for Joanne. Joanne, you mentioned that some of your technical assistance to practices involves data analysis. I wondered if you encountered any issues with practices regarding privacy and sharing patient data, and if so, how did you handle those?
The one thing that we didn't do was we never gathered patient information. We only took numerators and denominators for practices. At IPRO, we don't, and if we do look at their data, it stays in the office. But we do not gather patient information here at IPRO. That isn't with all of our projects. Everything is just numerator and denominator, and that's the information that we would share with Nadia and her group, as well as with the cardiovascular project that we're doing for laparoscopic work. So that's an issue for us. Mm-hmm.
Oh, thanks for that clarification. And then final question for Jennifer. Could you talk to us very quickly about how did you get buy-in from the office staff? Like, what was that initial contact like as far as getting them engaged with Project Impact?
Hi, thank you. This is a great question. So I was talking about getting buy-in from the office staff with regards to the community health worker intervention, but I can step back and talk about our initial recruitment of these practices because by the point of the community health worker intervention, we've already been working with them for a year doing the EHR intervention. But in the initial recruitment phase, when we were just going out to practices, first we worked with Health First to identify a set of practices that were members of Health First and who we thought would serve our target patient population. So these were practices in neighborhoods that were that had high child age and patient populations. In some cases, Health First was able to provide language data on the providers, so we knew if they spoke particular South Asian languages. And so then we would, we had a set of materials, recruitment materials about the project that we would literally go to all of the offices and leave with the staff and ask them to review it, to share it with the provider. If the provider was available or the office manager, we tried to speak with them at that time and just gave a brief overview about our project. And then we would try to schedule a 15-minute meeting with the provider where we went over a PowerPoint presentation about the project. And this was really just describing the two-pronged approach that Dr. Islam spoke about, which was the first, the EHR intervention and what the benefit was to the practices, and also the secondary community health worker intervention. Joanne accompanied us on a lot of these visits, and so Joanne was able to really speak about how IPRO engaged with practices to improve their use of the EHR, and I think that was a great selling point as well. And I'm sorry, I think we're out of time.
Yes, we are. Thank you so much for everyone for attending, and thank you again to our speakers for helping us with this event. Please, as a reminder, be sure to fill out the evaluation when you click off the WebEx, and we hope that you'll join our next webinar. Thanks. Goodbye.
And this concludes today's conference call. You may now disconnect.
Well done.